Now we switch our attention to the treatment of childhood apraxia of speech. Of course, we've actually been talking about treatment since the beginning of this video because, as we have discovered, the road to good treatment is first in good differential diagnosis, but also in paying a lot of attention to your assessment data to try and determine those best cues to use in treatment, to determine the best approach to use, to make all those important clinical decisions that we talked about earlier and that we'll expand on now. So what is it? What has to happen to engage the child in motor-based learning? Well, first of all, the motor learning literature tells us that in order to improve movement, the child has to have the intent to improve movement. That is, their attention has to be focused on this idea of improving movement accuracy. We have to help the child have this attention to movement by helping them really understand that we're going to be working on moving our lips, moving our jaw, our tongue, so that it'll be easier to talk. And think about how that's different than what we often say to kids, which is, okay, we're going to work on our sounds. Now we're just drawing their attention and their effort into paying attention to what it feels like when they move, to pay attention to what it looks like and sounds like when they move in different ways. So it's all about moving. In fact, when a child is just beginning therapy for apraxia of speech, I will usually start the initial sessions. We usually don't have to do this more than a few sessions, although sometimes I might go longer, with some non-speech activity just to draw their attention to the feel of movement. This isn't to improve speech itself, but it's a tool that they will use as we go through a variety of different treatment methods to improve the accuracy of movement. So maybe for the first minute or so, I might say, let's just practice moving. Can we make our face really, really tight? Now let's make it really loose. Now tight. Now loose. Because we're going to be giving them cues about tighten your tongue a little bit. Oh, not so tight. And we want them to feel comfortable with knowing what that feels like and what they have to do to make those changes. We might also encourage them to move their jaw big and move their jaw just a little bit. Big is pretty easy, and in fact, we talk a lot about jaw grading and we say, oh, they aren't getting their jaw to the right position. Really, that's just specifying the movement parameter in terms of the range of motion. So we practice moving just a little bit and then moving bigger. But again, what we're doing is just drawing their attention to what this feels like and drawing their attention to the fact that they can vary these parameters of movement, and that we'll be helping them do that. Again, these warm-up drills really should be focused on improving that child's attention and effort toward movement and are not necessarily facilitative at that point to any improvement in speech production, not in and of themselves. Now, what about those kids who aren't yet ready for direct integral stimulation type of treatment? Watch me, do what I do. And sometimes we begin with children that are either very young or perhaps pretty severely speech impaired and reticent to try to do things with us due to a history of failure. We might, especially for those children that can't yet voluntarily alter movement parameters, start with maybe the limbs. And we just practice moving big and then moving little. Big is easy, little is hard. Then we go fast and slow. Fast is easy, slow is hard. Then we go tight and loose. And we move from the arms to the fingers, which makes it a little harder. And we do the same thing. Let's move big. Let's move just a little bit. This is really helpful for cueing later in therapy if they can learn to volitionally vary these parameters. let's move fast. Fast is easy. Let's move slow. Slow is much harder. Tight, loose. And then we move to the jaw, then the tongue and the lips, until they become more adept at following directions. Make your lips tight, move your jaw fast, move it slow. Move your jaw just a little bit. These are parameters they'll need to vary in response to cueing in treatment. At the same time, we can work to develop better eye contact, which they may not be used to doing or not have a lot of experience in doing. And at the same time, we can sometimes work to decrease tactile defensiveness. All of these are prerequisites really to starting treatment, especially if in the implementation of any treatment program, any one of these things might get in the way. I often find that parents can be very helpful here. These kind of activities are best done 4, 5, 6 times a day, but only for like 30 seconds to a minute, working up to maybe a couple of minutes. Frequent but short little segments of practice throughout the day provide a better opportunity for learning to vary these parameters of movement. So I will often have the parents with me as I do this with the child, show the parents how to facilitate this. For example, if the child can't move small, they can only do big, we take their little hands and just do it for them. And then we say, okay, now I'm going to let go, you keep going. And if they go right into big, you bring your hands back. And then you fade that cue. You take your hands away as soon as you can, and if they lose it, you bring them back in. We know how to do that, but parents may not. So I find if I can teach the parents how to do that with the child, and they're doing it at home, within a week or so, they're usually able very easily to vary parameters of movement. Now later, when we're talking more specifically about treatment, we're going to emphasize a few things. First, we're going to emphasize that practice should focus on making the movement transitions, not practice on particular phonemes. At first, the clinician will provide maximum support by providing the visual, the tactile, the auditory models, but then fading those over time. And finally, because the actual goal of treatment is to improve movement accuracy, it's going to be very important that we understand and implement the principles of motor learning. And that's what we're going to talk about next. I'm going to be talking about what are principles of motor learning, and then we're going to go over just a few that have been shown in the literature and that I have found in my practice to be most helpful in not only motor learning, but in generalization of that learning. I should say in full disclosure that the motor learning principles were really developed with adults as the research participants, and with very simple movements, such as moving a object to a point. Very simple movement. Over time, though, more research has been done with children and with more complex movement, and many of the principles that I'll be talking about and how to implement them are based on that literature, where there is much more complex movement. Certainly speech is probably the most complex movement we do, and with younger children, where we start with more maximum support and then fade that support in order to facilitate generalization. So, the principles of motor learning are something that we are going to implement through our clinical decision making. So as this slide says, we're going to be coming to decisions regarding the implementation of motor learning. This goes back to what I said toward the end of the last segment. The method that we use is not the most important thing. There's several methods that have been shown to be efficacious for children with childhood apraxia at different levels of severity. And it's important to know those methods, which again are just a systematic description of a set of cueing strategies, but that the implementation of that method means you have to decide what are the stimuli, how are you going to organize practice, when and how are you going to provide feedback, etc. And the principles of motor learning guide us in that. We said that severity is going to greatly impact how we implement these principles. If childhood apraxia is quite severe, will be implemented in a way that addresses that severity by providing a lot of support at first to get the movement more accurate, but then fade those different levels of support as quickly as we can to facilitate the generalization of that skill and still get enough practice to allow the habituation of that learning. If the contribution of childhood apraxia is more moderate or even mild, we will still let these principles of motor learning guide our clinical decisions, but perhaps in a different way where we will implement them slightly differently and maybe to a little bit less degree. So the principles of motor learning come from the cognitive motor learning literature, and as I said, most of the data came from adults, but more recently, these principles have been applied to children. They've been tested for more complex movement, and in the last 10 years or so, we've seen more research studies looking at the implementation of these principles specific to speech therapy. And while some studies have shown that the principles of motor learning do apply to therapy to improve speech, a few have not. You really have to take into account that speech is a very complex movement and that language is interactive with speech. So depending on any particular child's language, potential language impairment, as well as any other coexisting disorders that the child may have, which as we know is common, you may have to implement these principles in different ways. So what is motor learning? Well, it's really just a process for acquiring the capability for producing skilled and volitional action. So what does that mean? Well, it happens by providing a lot of support so that the child gets a lot of practice, because motor learning occurs as a result of experience and practice. Now think about it. If we're working to improve the accuracy of movement and we let them practice the wrong movement over and over, we're kind of working against ourselves. So although I'll be kind of overemphasizing how much practice these children need, it can't be done just for the sake of practice. The quality of practice has to be such that the child isn't doing a lot of negative practice. And with some of the treatments, including DTTC, you have to really guard against that. And I'll explain more about that in a few minutes. This experience and practice, though, is influenced by a variety of factors. And these factors make a difference in therapy. So as we talk about principles of motor learning, I'll be talking just about that. So I'm going to be discussing just a few things that I have found and that the literature has provided evidence for that are most facilitative in not just acquiring more accurate movement, but in generalization and habituation. So we'll talk about a few precursors to motor learning, and then we'll talk about a number of these conditions of practice or things that make a difference, including you have to practice a lot, this idea of mass versus distributed practice, or in the case of organizing practice, blocked versus random practice, variability of practice, feedback, and the influence of rate. So these are the things I want to focus on today. Precursors to motor learning. On your slide, you see motivation, focused attention, and pre-practice. Well, we all know that kids need to be motivated. We tend to do that by making it fun for them. Obviously, we want them to have a good time, so they'll want to be there and stay engaged. What we have to be careful of, though, is to remember while we're there. And it's not just to have a good time. We're there to improve the accuracy of movement, right? Now, that doesn't mean we can't let the kids have some fun while we're doing this. Obviously, we can. But the type of reinforcement we use so that the kids stay engaged really influences how efficient therapy is. And we'll talk more about that. So motivating the child also from a motor learning perspective goes back to what are we having them motivated to do? We have to help them be motivated to do better at moving. We have to have them be thinking about, gee, I'm here so I can move more accurately, so I can talk better. Now, I never would have thought of that until I read the motor learning literature. And it really changes how I talk to the kids now. Instead of saying, okay, let's work on our words, or okay, let's practice talking, I usually say, okay, time to work on moving. We're going to move more accurately so we can talk better. I just put it in terms of moving. Their focused attention is to me, but also to this idea of feeling the movement. And pre-practice really just means it's good. The motor learning folks have shown that if you have a learner really understand what's going to happen, they do better. So I do that in a number of ways, and it's usually pretty short, and only when a child's first starting therapy. If mom's in the room, I might say, this is how we're going to do it. If I want your mom to learn a word with me, I'm going to say it and then she's going to say it. And if she has trouble, I'm going to help her. Let me show you. And then if the parent's willing, I'll do it with the parent. If a sibling is present, that's even better. You can do the same thing with a sibling. Sometimes there is no sibling or they don't want to do it and the parent isn't really comfortable. I have gotten permission from other parents to show children when they're starting therapy little clips. This is Jimmy, and this is what he does in therapy, and you're going to do something very similar. Watch what I do, and then I'll comment throughout about what Jimmy has to do. See how if he has trouble, I help him. All you have to do is try. And usually that is very, very helpful to the kids because then they know what's expected of them and what I'm going to do, and sets a stage for us actually. Now we said there was this variety or conditions of practice, a lot of different things that influence the efficiency of our therapy. The most important one is practice. And I will even go as far to say it. I'm really hoping you're understanding this paradigmatic shift in treating CAS versus what we typically do in phonology. But even if the only thing you changed in your practice as a result of watching this video is that you use reinforcers that are quicker and don't take their attention away from you, and you get more trials per session, you will see your therapy become more efficient. That is, progress will be faster. And I can pretty much promise you that. The motor learning literature talks about this quite a bit because, as they say, in order to learn motor skill, one must practice the movement in the context for which it will be learned. So that's pretty straightforward, and they've done some elegant studies to show this. That means we need enough practice trials every session for not only the motor learning to occur, that is the accuracy of movement to happen, but also so that it can become habituated, so that the child won't need to use so much conscious, focused attention. It'll become more automatic, like it is for us. We have to build this in, though, to our treatment planning. We have to think about it ahead of time. That is, we're going to use activities that keeps the child's attention to our face so that they're looking at us, watching our movements. We want to use reinforcements that don't take a lot of time and use activities that facilitate repeated practice. So let me give you a few examples of some that I've used in my practice. First of all, some kids, they're kind of antsy, and if we have them sit with their hands on the table like this, it's hard to keep their attention, isn't it? So I won't make them sit down necessarily, especially for a whole session, so I'll let them get up. And what we're going to do is I'll say, okay, I'm going to back up after we do 5 repetitions of this word. So I'll say it, then you say it. Tell me, boy. And then the child would say boy. And if it's correct, then I'll say, good, let's do it again, boy. And I take a step back after that 5, boy, 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 where we're taking turns in direct imitation. And then I take a step back and I say, don't let me touch that wall. So he's great with this. He's with me saying 5 because he can't wait for me to touch that wall. Lots of little different things we do. I have these Nerf basketballs and I put a little hoop up on my filing cabinet. Maybe we can get 10 responses and then they can try to make a basket right from where they are. Takes just a minute, he gets to move a little, we do 10 more. With some children, maybe we have to start with 1 when they get 1, we let them do it, and then we build to 2 and 3 and 4, and it often doesn't take too long to get up to, say, 10 in between each trial. We sometimes drop things in a basket after so many trials. We get up and jump whatever many times we practiced the word. Little girls check with their mom first, and if it's okay, the girls that like it love nail polish. 10 responses to do half a nail. You can get, hundreds of 200 responses by the time you get all your nails done. I bring these bracelets in there that you can get in dollar stores, and I hold it right here so they're watching me, and if they do so many trials. Now remember, these aren't necessarily correct trials. These are trials where I'm shaping toward more accurate movement, but after we do a number that I think is appropriate for that child at that time, I'll put it on my forearm here, and when they get to the top, they get to take one home. 200-300 responses sometimes, but they're so engrossed in waiting for it to get to the top so they can have one that they stay with me. So there's lots of different ways to do this, and you're probably more creative than I am even at thinking of these things, but I think we have to get out of this idea that we always have to show them pictures, or we always have to have a game on the table, or they always have to be sitting at a table like this. I think we have a lot more degrees of freedom than that. The downside to this need for repetitive practice is that the clinician and or the child can go on automatic pilot. Remember, if it isn't going through cortex, learning isn't happening. And if they just start brr, 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 repeating, and there's no changes being made, and you're not paying attention and shaping the movement, adding and fading cues the way you need to, then learning isn't happening. So we have to be very careful about the quality of practice. So not only just keeping their focused attention and being careful about the types of feedback and when to add and fade cues, we have to really listen to that they're not doing a lot of negative practice, because that's going to take us in the wrong direction. So this is hard. You got to really pay attention to every response that they give you, and then you're either adding or fading cues depending on the success of that response. Which leads us to the next aspect of these motor learning principles, which is that practice can lead to different outcomes, and that there are ways to implement motor learning principles that will either facilitate motor performance and perhaps hinder motor learning, or may be really good for motor learning, but it will take the child forever to get accurate. So let's differentiate this motor performance from motor learning. Motor performance is just the term that we use to talk about the skill shown during the session with the therapist providing the cues. What kind of performance is the child doing with us providing therapy and cueing? Versus motor learning, which we know as generalization. That is, being able to use that motor skill, let's say a certain syllable shape with certain vowel content in a certain co-articulatory context, at another time, in another context, with another person. So we know that as generalization. What I'm going to talk about next, the next couple of things, if we implement the principle I'll talk about, let's say blocked versus random practice, if we implement that in one way, we are going to facilitate motor performance. That is, they'll get accurate more quickly. But if we stay with that level of cueing, say very massed practice, blocked practice, we risk their being able to generalize, or we risk motor learning. On the other hand, if we start with more random practice, which has shown better retention or learning, with a child that has significant praxis problems, it'll take them forever to get accurate. So there's been some research in the child literature, especially with more complex movement, that have shown you have to start with more massed practice and then fade to random. Because first you have to get the child accurate and then provide enough practice, not just for habituation, but also for learning. But that practice has to become more random and with less cues. So that's the concept in a nutshell. And now we'll talk about how we implement that very specifically with a couple different principles of motor learning. And we'll start with mass versus distributed practice. And within that, we're also talking about blocked versus random practice. So mass versus distributed practice is pretty much what it says. Mass means all at once, distributed means separated out across sessions. So we can think about this in terms of frequency of sessions. So you can have one session a week for 2 hours. That would be an example of very mass practice. Or you could have therapy every day for half an hour. So that's more distributed practice. We know that for childhood apraxia of speech, it is much better to provide shorter sessions more frequently, distributed over time. So in some of the dosage work research that we did in treatment efficacy, this was with DTTC, we looked at very distributed practice, maximizing response trials per session, and we saw the children twice a day for a half hour, 5 days a week. Now this was a research setting, of course. Well, it was a real clinical setting, but we brought the children in for this research study. And we saw quite a difference in the rate of progress relative to what had been going on in therapy for them in the few previous years. So dosage is huge, but also the dosage in the sense of frequency of sessions. You can also think about mass versus distributed practice in the context of your stimulus set size. So remember, we said that stimuli, what you're working on, is just a vehicle to practice the efficiency of the processing that's not working so efficiently, right? So for years as a young speech pathologist, I never thought about choosing a certain set size for stimuli. Probably because I'm getting old, and in those days we did mostly artic therapy, and I'd go get my box of S cards, or my box of R cards, or my box of F cards, and whatever was in there is what I did, and I never thought about it. Now for most of those kids it didn't matter because we weren't really working on movement accuracy. We were working on really making salient the distinctive features for that phoneme, or working on suppressing a process, whatever. But for children that have apraxia of speech, this mass versus distributed practice really does come into play when we make clinical decisions about stimuli. We said that severity plays an important role here, and indeed it does. If I have a child that's nonverbal or very low verbal, and in dynamic assessment they make improvement with cueing, but they need lots and lots of cueing, I have a lot of evidence that the efficiency of their motor planning and programming isn't very good. So I would say they have a severe CAS, and I'm going to choose a much smaller set size so that they can have some rapid improvement fairly quickly. So you never want to start too small. For example, you'd never just work on one word, because the motor learning literature also tells us we need some variability in our practice. So 5 would be the smallest set size I ever use. So I usually, if for children that are nonverbal or very low verbal, I might start with 5, 6, 7 stimuli. We'll talk more about stimuli in a few minutes. Also within this mass versus distributed practice is this concept of random versus blocked practice. Blocked practice is what you might expect, where you take one of your stimuli and you practice it in a block, let's say 200 times, put it away, take the next one 200 times. I'm just saying that 200 doesn't mean anything, just a lot. Put it aside. And you do completely blocked practice. Random would be taking each of your stimuli and practicing it once and then just jumping all over among all your stimuli. Well, neither will work very well at first if a child has more severe praxis problems. If you're too random in your practice, it will take way too long for a child with any severe praxis problems to get accurate. If you start with completely blocked practice, then you risk over-habituation and there's not enough variability of practice. So we tend to use severity as our guide. We know that mass practice is going to yield quicker development of the skill, but it might hinder generalization. And we know that if we use distributed, it'll take longer, maybe too long, to get anything accurate to begin with. So if the CAS is quite severe, we usually start with more blocked practice, but use what we call a modified blocked approach. So let's say if we have 5 stimuli, I would practice number 1 for maybe 20 to 40 responses, depending on the child and your choices and your clinical thinking, and then we move to the second stimuli. Now, we can then go on to the third stimuli, but another way to think about it is, gee, this child's just starting. They've been in therapy for quite a while and made very little progress. Now I'm taking a new approach. I'm implementing the principles of motor learning. I want them to trust me and I want them to trust the process. So maybe I'm going to pick a couple, 2 out of these 5, 6, or 7 to get extra blocks and extra practice within each block. So I might do stimulus number 1, 40, 50 times, stimulus number 2, 20 times. Back to number 1, 40, 50 times, then to number 3. Then to number 1, then to number 4, back to number 1, then number 5. You could do the same choosing 2. So you do 1, 2, 3, 1, 2, 4, 1, 2, 5, that kind of thing. There's no rules to this. It's the concept that's important. You want to use this modified block, meaning that you're going to do blocks of each of your stimuli. But choosing that maybe 1 or 2 of your items will get additional blocks or more repetitions or trials within each block. For those of you that will be applying to and coming to the advanced workshop, we're going to have practice with real cases, choosing the stimuli, and then given the severity and other factors that are important to that child, you'll be choosing how are you going to organize your practice with respect to the blocked versus random. Today I just want you to get the concept of what this means. What is blocked practice? There are some readings that you'll have a reading list, some of which will be required, some of which are not. And these, some studies looking at these exact principles will be in those readings. Variability of practice. There's lots of ways that the motor learning literature talks about variability of practice. I want to focus on things that I have found to be real meaningful to speech therapy with children who have apraxia, at least in my practice. There are lots of ways to bring in this variability. One, we'll talk about again later, has to do with varying movement sequences in different contexts. So it's how you choose your stimuli, basically. So you may choose stimuli for a particular movement sequence, maybe movement from lip closure to an open vowel, but you want to do it in a couple of different co-articulatory contexts. So let's say you're at the CV, VC, reduplicated syllable. I might have mama and papa and maybe boy. So I've got bilabials in 3 different contexts across 2 different vowels. So I've got some variability there, but not too much. So that's the concept. Another example would be the initial set, maybe me, my, boo, baby, and then 2 or so that are totally different, like no and eat. So that you have the bilabial 2 different vowels, but you also have a bisyllable and then a couple VCs. So that you have some variability, but you've also got 4 lip closures to different vowels, so that you've got some variability there, and yet you're really working on that one movement gesture. Now here's another way to add variability, and it's also a way to begin working on prosody very early, even when they are at a CV, VC level. Although I usually put some simple bisyllables in early, and not in the first set, I'll bring it in fairly soon. So for example, once they become accurate, so let's say we've worked on hi, bye, no, me, and mom to get one CVC. So we're working with each one individually, and they'll progress at different rates, right? And you're keeping track of the progress of each one individually. We'll talk more about that. And let's say hi is the first one. You've given it a few extra blocks, and it's the first one to be accurate, normal rate, and you're going to start varying the prosody. Hi, 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 where he's going to or she's going to imitate your prosody. Think about what that does for motor planning and programming. Even though it's the same articulatory target, this continuous movement gesture, they're changing everything about motor programming. They're recruiting different motor units, more or less motor units, for all the respiratory muscles, for the laryngeal muscles, as well as the oral articulatory muscles, to vary that prosodic emphasis. Sometimes everything's a little longer, higher pitched, louder, softer, so that changes up the motor planning programming requirements. So you're adding that variability, which is strengthening the motor planning processing, which is the goal, right? Making it more efficient, strengthening it. We'll talk more about that when we get to treatment. The next principle that's very important to think about when we're planning, but even more so when we're implementing treatment, is that of feedback. We all know, we learn undergrad and graduate how important feedback is, and we know it just because it makes sense. We know that intrinsic feedback is what the child hears, feels, sees himself. Extrinsic is the feedback we provide the child. It's generated outside the learner. And this can be either just knowledge of results. Good, that was good. Or, oh, not quite. Can you fix it? So we're just letting them know if they were right or wrong. Or we can provide knowledge of performance, which is much more specific. That is, we give them information about the movement outcome. Oh, that was too tight. Oh, don't open so much. Close your jaw a little bit. Where we're being quite specific about what they need to change to be more accurate. And we can provide this specificity of feedback verbally, close your mouth a little, or with gestures, or both, or tactile cues. What do you think? I want you to think about this just a minute. What do you think would be better to improve motor performance? Do we want to give them a lot of specific feedback or just knowledge of results? Now, if we were all in the same room, I'd be asking you to tell me your answer and why, but since we're not, I'll tell you what I think. And that is, if we provide a whole lot of specificity, we're giving them more support, aren't we? So that's going to improve performance. But if we stay with that, if we give them too much specificity for a long period of time, we're risking their ability to do that for themselves. Therefore, we're risking generalization. So the key is that we have to provide a lot of support, real specific feedback, but then fade that specificity so that it's less frequent, less specific, until we're just giving them knowledge of results, until we're doing that less frequently, until we're not providing any feedback at all. We may be just looking at them to see if they can self-correct. This is really important. And I've had people ask me at workshops, well, do you keep track of this during therapy? Like you provide so many trials with specific and then, no, we don't. You can't. You're paying attention to too many things. This has to be clinically intuitive to you, so it takes practice. Watch yourself on tape. Watch yourself doing therapy. Yeah, it can be excruciating, believe me. I've had to do a lot of it because I teach. But you get over that. And if you do it alone in your bedroom, nobody cares, right? Except you're going to learn a lot about your pacing. You're going to learn a lot about, am I providing too many cues? Am I catching myself and fading those cues soon enough? That's the best way to help yourself get better. Watch yourself do some of these therapy sessions on tape. Better yet, get a colleague or two who you trust to watch it with you, and you watch theirs, and you critique each other. I mean, if you're a basketball player, you go to practice all the time, right? And you're getting feedback from your fellow players and from, I act like I've ever played on a team. I was before Title IX. I've never played sports in my life because they didn't let girls play. But I would think that would be the case where, you know, no one's ego's involved. You're playing the game, you're getting feedback. Next time you shoot, do it this way, that kind of thing. We can do that for ourselves and with each other, and I don't think we should be afraid to do that. We should be doing that a lot. So just to review, feedback, knowledge of results is just right or wrong. Knowledge of performance is actually what happened. What should the child do differently? We need to provide a lot of extrinsic, what we're giving them, feedback, and very specific feedback earlier and when they're more severe. As they start to become more accurate, we fade that. We fade it to knowledge of results and less frequently. It will become intuitive, and you'll just gradually be doing that as you notice them improving. But don't tie yourself up in knots trying to keep track of how many times you did each. Okay, so we talked about all of that. Timing and frequency of feedback. Immediate feedback we want to use also early in treatment and when the child's more severe. That is, we're going to provide the feedback right away. As they become more accurate, not only will the specificity of that feedback become lessened, not quite. What are you going to do differently with your jaw? Have them think about it. But you're also going to wait a second before you provide that feedback to see if they'll start self-correcting on their own. All right, so there we go. That's the principles of motor learning. At this point, I would ask you, what questions do you have so we can review some of this? Many times when I'm speaking to an audience, this is the first time people have heard anything about these motor learning principles, and it can be a lot to assimilate at first. So I want you to stop, maybe pause it here for a sec, think about it a little bit, see if you have any questions, and then go back in your handout and see if you can answer it yourself. If not, come to the advanced workshop and we'll have actual practice in doing this. Right now, let's move on to some additional general comments on treating the praxis impairment in CAS and things we need to do to facilitate motor learning. There's some overlap here with the principles of motor learning we just talked about, but these are additional general comments. In order to get the frequency of practice that we've talked about, as I said, we want to schedule shorter and more frequent sessions. And we want to maximize those practice trials per session by bringing in reinforcers that take very little time, providing very novel tasks to keep them with you. And you'll see examples of this on some therapy video that we'll have in our next section. And we're going to use reinforcers that are chosen specifically to keep their attention to your face rather than to what's on the table. With respect to modifying the use of rate, this can be really helpful in getting the children more accurate, especially at first. I find that if I keep them looking at me and slow the model and have them produce it maybe even slow and simultaneously with me, children can do things they may have tried a million times and could never get accurate. And when we add that level of support, they can do it. You'll see some of this on the tape as well. So I always recommend for a child with more severe CAS to produce the movement for the utterance very slowly at first. Maybe, as I said, simultaneously or in unison with the therapist, and then gradually increase that rate with continued practice trials until it's normal rate, natural rate, and finally with normal prosody. Now, sometimes even in simultaneous, the child may have difficulty. So you've tried, let's say, 5, 8, 10 times or whatever, and they just can't even do it simultaneously. And maybe the problem is they can't really get in that initial configuration very well. So what you can do, and this comes back to proprioception. I think I said earlier that we don't even know to what degree are these kids really efficient at processing this afferent proprioceptive information. So this is a pretty simplistic way to think about it, but if we're not sure how to do that, let's at least give the brain more time to do it. So one thing that I'll do is if they're having trouble even with simultaneous is to slow it perhaps even a little bit more and then have that child stay in the initial articulatory configuration. So let's say we're going to do one or why or where. So it's lip rounding to begin with, and that's what they're having trouble with. You might just get them there with a tactile gesture, and you stay there. And you say to the child, stay there. I'm going to let go. You just stay there. If they lose it, bring it right back. Stay there. Feel it. And then while they're staying there, you're saying, okay, feel what that feels like. Your lips are round. They're just in the right place. Feel that. Sometimes the kids will go. And that's okay. They don't need to do that because really they need to feel this. Because that's what we don't go around talking like this, right? So you have them stay there for a second or two before actually starting the movement. So it's one or why, which is an important word early on. The use of slower rate or perhaps staying in the initial configuration really helps make salient that proprioceptive processing, which I think is an important part of treating childhood apraxia of speech. But I like to do it in the context of speech and especially in the context of the target that you're currently working on. Remember, which is just a vehicle to improve the processing. Then the other thing that's really important goes back to the principles of motor learning, which is that of feedback. And we've already talked about this at some length, but it's one of those other kind of additional strategies that people talk about that's so important in treating CAS. So the more severe, the earlier in treatment, frequent feedback, very specific, fade the specificity, fade the immediacy, and fade the frequency with how much you provide the feedback. Now, one thing that I want to keep in mind is when we talk about DTTC later, we're going to have a set of stimuli that we've chosen very carefully and a certain number of stimuli that we've chosen for a reason. But within that set of stimuli, and this is something I want to talk about because it's misunderstood a lot, this set of stimuli isn't like one thing, and we're always at the same level with all of them, and they're all done at the same time, and they're all at the same level of feedback. Each one's different. So let's say item number 1, let's say, is high. That one you might be doing with direct imitation or even at delay, which is part of the hierarchy of DTTC, and you might be varying prosody. Whereas if you're working on no, maybe you're still at slow simultaneous production. So everyone's different in terms of where that particular stimulus is in your training hierarchy. And also, each one is going to reach some specified, you're going to specify the criteria for when it's done being in treatment, and then it goes out to a generalization phase and a new one comes in. That'll be up to you to decide, but they'll all go out at a different time. Keep in mind, too, that as therapy proceeds, they're going to start, the processing does improve. If your dosage is high enough, we've shown this with our research, that kids, the processing gets better and they'll start achieving accuracy of these words more quickly. After the first few weeks even, 3.5, 4 weeks is the big point where we see with that very frequent therapy, where they're starting to really get them much more quickly, where we could take one out and bring in 2 new ones and gradually increase that set size. Maintaining co-articulation and movement. This is so important. I have particular interest in making this point because in our field we're taught a technique that works really well with kids that have residual artic errors, especially kids with phonologic impairment, where we make the distinctive features salient by separating the sounds. So say we're working on a velar, we might go cat, or at, or even at. The trouble is then you're teaching that child the movements for k and a and t, none of which are the target, which is, you have to watch me for this. If you're doing dishes and just listening to this at home, I guess you could be doing that. You have to watch me for just a minute. So remember how I said the focus of treatment is movement? So the focus isn't cat or boy. This is it. You have to watch me. This is the focus. Now, of course, we're going to do that acoustically because we're working on speech, and it's not like the sounds aren't important. But the movement is what results in a particular acoustic output. And for kids that have difficulty with this movement specification, that's what you have to focus on so that the acoustic output is good, right? So it's that movement gesture that's important. The other thing that makes this point, I think, is that if we just think about phonemes, and then we try to put that in a word and we think ba, oi, ba, oi. Not only are we teaching two wrong movement gestures relative to your target, but we're saying take your inefficient motor planning system and put those two wrong movement gestures into one good one. You know, we're just making it harder. Look, I want you to think about this too. The movement for the bilabial voiced plosive is this, right? But look at how it changes when we change the co-articulatory context. I'm going to say the words bow and bee. I'll say the first one first. Bow, bee. Movement for lip closure occurs in both. But in one, you have lip rounding as the initial configuration. Bow. In the other, you have lip spreading. B. So we're working to improve the accuracy of the movement for the co-articulatory context. That's what we do in speech. And if we're teaching ba, oi, we're teaching two wrong movement gestures for one accurate movement gesture, which is either bow or be, by. All of those are uninterrupted movement transitions to result in an acoustic output that's understandable to a listener. So it's extremely important to avoid pausing in voicing, pausing in the movement within syllables, because we have to use our carefully selected stimuli in a way that helps them learn movement accuracy in the context for which it will be used, which is that target syllable. Okay, so while this might be an appropriate technique for children with some phonologic problems, it's really contraindicated in children with CAS. And it would be my suggestion that you never do that. We've had a few people come to Mayo, kids who have been in therapy for several years, and they do that with every word. They'll separate that first sound from the rest of the word, or in the case of one extreme example from a little boy from Canada who this. And it took 2 weeks, 2.5 hours a day to extinguish that before we could even get started. And he wasn't the only one. So you don't want to have to deal with that. So it's my suggestion that while we very seldom say something is really wrong, don't do it, this is one thing where I think we're going backwards. We're kind of harming the child in the sense of we're doing therapy that's actually going to make it harder for them to be accurate. And prosody. We'll be talking more about this. It's so important for children with apraxia of speech to begin to work on prosody very early. One of the ways we already talked about doing this is when we vary the prosody to bring in variability of practice, even with monosyllables. Once they're accurate, we start mixing it up. Mom, 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 mom. And when we get to DDTC, you'll see that we kind of do this at each level of the hierarchy. It's also important to work on lexical stress early. So within the first few weeks of therapy, I like to bring in either some reduplicated syllables or even bisyllables like puppy. Mama, dada are easier, but puppy, baby aren't too hard. And then you can start to work on lexical stress very early. All right. Now we're going to move to treatment planning and the implementation of treatment techniques.